This conference will now be recorded.
Good morning, everyone. This topic is urology. It will be covered by third unit newly joined professor. So just I'll be covering only regarding anatomy and embryology of kidney and bladder and ureter. So this is my first class regarding urology. Coming to kidney and ureter. See, this topic urology is very important. Usually in second paper, second part, the essay question will be from urology, and at least 1 or 2 4 marks questions will be coming from urology part. So just concentrate it. Everything is from only Bailey. So if you listen carefully to these slides, there is no need to again start reading it from Bailey. So coming to anatomy of kidney, these are a pair of excretory organs situated retroperitoneally on the posterior abdominal wall, vertically extending from the upper border of T12 vertebra to the center of body of L3 vertebra, and the hilum of kidney located at the level of L1 vertebra. Remember, upper border T12 to the center of lower L3 vertebrae, whereas hilum of kidney is located at the level of L1 vertebra. Each kidney is about 11 centimeters long, 6 centimeters broad, and 3 centimeters thick. And lateral border is convex, whereas medial border is concave with hilum. And if you see, mostly on the right kidney, there will be a hump located on the right kidney that is called as dormitory hump. This is not much important for you, but just remember there will be hump located over the right kidney. Then what are the structures located in the hilum? This is very important thing. The structures located in the hilum in regarding to anterior to posterior. See, from anterior to posterior, what are the structures in the hilum? Are first, see, there is a mnemonic for this. VAUP. V for vein, renal vein. A for renal artery. U for ureter or renal pelvis. Next P is for posterior segmental artery. So these are the 4 structures seen in the renal hilum from anterior to posterior: renal vein, renal artery, ureter, and posterior segmental artery. VAUP. This is very important thing. Yeah. See, then coming to one important relation. Remember, I'm telling this again and again. One important relation between the kidney and adrenal. See, the right kidney is located lower than the left kidney because on right side there is a liver, so it will push the right kidney down. So the right kidney is located in the lower extent when compared with the left kidney. Whereas coming to adrenal, it is opposite. The right adrenal is located superiorly, whereas left adrenal is located below at the level of right adrenal because of the shape of the adrenals. The right adrenal is top hat shaped, whereas left adrenal is crescent shaped. So the left adrenal is usually located at the lower level, whereas left kidney is located at higher level. This is very important relation you need to know. Right kidney lower level, left adrenal lower level. Okay, then the capacity of renal pelvis is around 10 ml. This is very favorite question for every professor. This segment. The angle between the 12th rib and outer border of sacrospinalis is called as renal angle or kidney angle. Why? Because any kidney pain is usually referred here, and pressure over these points elicits pain in the kidney lesions. This is very important. What is renal angle? Renal angle is the angle located between the 12th rib and outer border of erector spinal muscle or sacrospinalis muscle. This is very important, renal angle. Then one of the important pouch called as hepatorenal pouch. This is one of the dependent pouch in abdomen where when patient lies, if a patient underwent surgery and is lying constant in the bed, So it is a dependent position. So any collection in the abdomen will get collected into the dependent part of the abdomen, usually in the right side located between the liver and kidney, that is hepatorenal pouch. So hepatorenal pouch is a peritoneum lined deep recess related to upper pore of kidney. Collection of extravasated fluid is likely to occur in this pouch following surgeries to liver and biliary tract if the patient is in the lying posture. If patient is in standing posture, usually the collections will be noted in the pelvis. Then the capsules of kidney. So there are basically the capsules of kidney are proper capsule. This is nothing but the fibrous membrane which can be easily be stripped off from the organ. Next, perirenal fat in the space of zerota. Then the fascia of zerota. See, fascia of zerota. This is the see first from inside. We will be seeing from inside. First, kidney will be there. Kidney is usually surrounded by proper capsule. Next, outer to the proper capsule of the kidney, it is surrounded by the perirenal fat. So this kidney, perirenal fat, renal vessels, ureter, adrenal, everything will be lined by fascia of zerota. So this fascia of zerota, how will be present? Remember, like this will be like, it will be like, see, if this is a kidney, if this is a kidney, this fascia, anterior lamina, this is a posterior lamina of fascia of zerota. This anterior lamina is also called a fascia of Told. This posterior lamina is also called as fascia of Zuckerkandl. This anterior lamina comes like this. This posterior lamina surrounds the kidney like this, and it is open inferiorly. So very, very important. Zerota's fascia is opened inferiorly like this. This is a kidney. It will be fused here. It will surround like this, whereas inferiorly it will not fuse. So very, very important is fascia of zerota is opened inferiorly. That is why if there are any collections in the kidney or surrounding system, it will trickle down inferiorly, but not medially or laterally or superiorly. It will trickle down only inferiorly because the zerotus fascia is tightly adhered surrounding, and inferiorly it is open. Then surrounding the zerotus fascia, there will be pararenal body of fat. Then structure of kidney, gross structure of the kidney. You know that is a cross section consists of cortex and medulla and renal sinuses. The cortex is usually outer brownish cortex and inner pale medulla. Then the renal sinus is a space that extends into the kidney from the hilum. It consists of renal artery, renal vein, and renal pelvis. The pelvis is again divided into 2 to 3 minor calyces, which inter divides into 7 to 13 minor calyces. See, one important thing I am going to tell here is this is cortex, right? This is medulla. So these are the renal pyramids. These renal pyramids will be opened through a renal papilla. The opening of the renal pyramids is renal papilla. This renal papilla will open into minor calyx. All these minor calyx combines and opens into major calyx, right? These are corticomedullary junctions. See, this is medulla, right? This is cortex. This pink one is cortex. This cortex is extending between the medulla, between the renal pyramids. This is called as columns of Buttin. These columns of Buttin is very, very important because the vessels, see, renal artery, renal vein, the vessels are located in the columns of Buttin. So while doing, here the vessels will be located. So while doing any surgery to the kidney like PCNL, you need to be very careful while going to these columns of Buttin. So it may damage the vessels. So better thing is you go into renal pyramids. Remember, I am telling you again, these are the renal pyramids. These renal pyramids will open into the minor calyx via renal papillae. This opening is called minor papillae. This minor calyx multiple will join to form major calyx, which in turn drain into the renal pelvis. This is renal pelvis. Again continues as ureter. This is the cortex. This cortex is extending between the medulla. This is called as columns of Buttin. This is very important because the vessels are located. The branched renal artery and renal vein are located in these spaces. So while doing any PCNL surgeries, you need to be very careful to prevent injury to this. You need to enter into the kidney via renal pyramids. Coming to blood supply, this is again very important segments of kidney. See, this is the kidney division. It is first divided into apical segment and lower segment, then upper, middle, lower and posterior. Total 5 things: upper, middle, lower, apical and posterior. So the blood supply, it is usually from the renal artery, which arises from the aorta at right angles at the level of intervertebral disc between L1 and L2. See, remember structures located at the level of L1. I told you renal hilum located at the level of L1. Renal artery branching from aorta at the level of L1. Cisterna chyli at the level of L1. See, remember these 3 things. These are the structures that are located at the level of L1. Whereas coming to in kidney, you need to remember at L1. Renal artery branching from aorta is present, and renal hilum is also located at the level of L1. And the kidney is divided into anatomical segments based upon the blood supply. Like, see, the segmental artery will be coming from the renal artery. It will come like this, and it will divide into anterior and it will divide into posterior. So this posterior segmental artery will supply the whole posterior segment of kidney, whereas this anterior segmental artery will divide into apical, upper, middle and lower branches. So remember, this is the renal artery. It divides into anterior segmental artery, posterior segmental artery. Posterior segmental artery will supply the posterior segment of kidney, whereas the anterior segmental artery will supply apical, upper, middle, lower. In the hilum, the main artery divides into the main artery divides into anterior and posterior divisions. The anterior divisions supplies the apical, upper, middle and lower segments, whereas the posterior segmental artery is supplied gives the posterior segment is supplied by the posterior division. And you need to remember this very important thing: there is a functionally avascular plane called as space of Brodel, is located between the posterior segment and upper and middle segments, that exists on the posterior half of kidney, about 2/3 away from the hilum to the lateral margin of kidney. Right? This is the segment. This is located between the, this is the space of Brodel. This is nothing but avascular space. So because a whole part of kidney is highly vascular except this part, because it is a junction part. So it is located between the posterior and upper middle segments. So this is avascular part. So any surgery to the kidney during open surgeries, you need to give incision through this space of through this avascular plane of Brodel to prevent hemorrhage. So yes, this is renal artery, divides into anterior and posterior segmental arteries. This is anterior artery, this is posterior artery. So posterior artery will supply the posterior segment, whereas anterior segmental artery will supply apical, upper, middle and lower. These things you people need not know much. This arcuate artery, interlobar artery, lobular artery, these things are not needed much for you. Then coming to now supply, it is supplied by T10 to T12 lesser and lower splanchnic nerves. Coming to lymphatic system, very important. These are drained into para-aortic group of lymph nodes. Then the perinephric fat is removed during nephrectomy for malignancies. This is very important. Surgical anatomy. Why? The perinephric fat is always should be removed during the any surgery of any malignant surgeries to the kidney, is because this perinephric fat is very high in rich in lymphatics, because and also it will communicate with the intrarenal lymphatics. So perinephric fat is removed during nephrectomy for malignancies because these intrarenal lymphatics freely communicate with the plexus in the perinephric fat. So high chances of recurrence. So hence we need to prevent, to decrease the level of recurrence, we need to remove perinephric fat also during nephrectomy. This is all about anatomy of kidney. This is regarding anatomy of kidney. There will be while coming to congenital anomalies I will be explaining regarding embryology of kidney. So next, remember regarding anatomy of ureter. Each ureter is around 25 to 30 centimeters long. It begins within the renal sinus as a funnel shaped dilatation called as renal pelvis. It enters the bladder obliquely to open at the lateral angle of trigon. It lies in the retroperitoneal space, not attached to any structures, so it can be displaced or obstructed by retroperitoneal masses like tumors or aneurysm. Then ureter is divided into, see, abdominal portion, pelvic portion. Abdominal portion of ureter located on the medial portion of psoas muscle near the tips of transverse process of lumbar vertebrae. Then ureter enters the pelvis, crossing at the end of common iliac or beginning of external iliac artery. In females, the uterine artery crosses the ureter from lateral to medial side about 2 centimeters lateral to cervix. See, these things are not much needed for you, but remember one thing: what is the relation between the ureter to gonadal vessels, ureter to uterine vessels? Is nothing but you must have read the mnemonic in anatomy: water under bridge. So there is water under bridge. So ureters are located posterior to gonadal vessels or uterine artery. Only vessel where ureter is located anteriorly is iliac vessels. Then coming to arterial supply. See, remember, ureter is again divided into 3 parts: upper part, middle part, and lower part. Upper part usually gets the blood supply from, it gets a blood supply medially, whereas middle part will get posteriorly, whereas lower part will get blood supply laterally. So the upper segment of ureter receives blood supply from renal and adrenal arteries medially. The middle portion of ureter gets branches from the arteries of posterior abdominal, so it receives blood supply posteriorly. In the pelvic or lower part will receive blood supply from internal iliac arteries laterally. So why I am keep on stressing these things are, while doing endoureterotomy, that is, you are giving incision over the ureter, you need to remember that you should not injure the vessels. So because upper part of the ureter is getting blood supply medially, you need to give incision laterally. Because of the middle ureter getting blood supply posteriorly, you need to give incision anteriorly. Because the lower ureter is getting blood supply laterally, you need to give incision medially. Vessels reach the abdominal portion of ureter on medial side, whereas pelvic portion, see, the pelvic portion vessels reach the abdominal portion of ureter on the medial side. Middle portion posterior, whereas pelvic portion on the lateral side. This is what I am explaining. Yeah, first coming to, I'll explain the embryology, then you will be knowing about congenital anomalies. Yeah, coming to this kidney. So kidney is developed from, remember, it is, kidney is embryologically derived from intermediate mesoderm. Remember, again I am saying you, kidney is derived from intermediate mesoderm. So first, initially there are 3 types of nephros: pronephros, mesonephros, and metanephros. See, the pronephros is usually, these 3 things are usually present in every fetus, whereas pronephros is usually spontaneously regressed. Next, mesonephros and metanephros. Mesonephros, it will form the mesonephric duct. From this mesonephric duct only this ureteric bud will arise. Then metanephros, also called as metanephric blasphemy. So this is the ureter bud. If I have some board or something, I can explain you better. This is ureter bud or mesonephric duct. This is metanephric blasphemia. So from mesonephros, this ureter bud and ureter develops, whereas this metanephric blasphemia or metanephros, the future kidney will arise. Coming to congenital anomalies of the kidney, there will be unilateral renal agenesis, where there will be complete absence of one kidney, usually autosomal dominant type, usually associated, always unilateral renal agenesis, usually associated with the ipsilateral absence of ureter and ipsilateral absence of hemitrigon, whereas the adrenal is usually located because the embryological origin is different. Only the position alters, whereas the adrenal is normally developed even in the patients with renal agenesis. This is the thing very important to remember. Then coming to remaining kidney. The remaining kidney is usually hypertrophic but may also be dysplastic. Then in males, the ipsilateral testis and the vas difference are usually absent, and in some patients the adrenal gland on the affected site is missing as well. Females may have an absent ovary or fallopian tube. See, this is very important 4 marks or 2 marks question for you. Unilateral renal agenesis. If there is absence of ureter bud, then obviously 100% there will be absence of metanoblastemia, so there will be unilateral agenesis. If you think there is unilateral agenesis, you need to also remember that the patient may also have ureter bud, absence of ureter bud. So unilateral agenesis. Then bilateral renal agenesis. Usually this unilateral bilateral renal agenesis patients present with Potter facies, like because of absence of kidney there will be oligohydramnios. So if there is oligohydramnios, abdominal contents will go and compress the diaphragm. So if this diaphragm is pushed up, there will be pulmonary hypoplasia. So mostly that is why bilateral renal agenesis babies will not survive because of associated severe pulmonary hypoplasia and Potter facies due to oligohydramnios. See, bilateral renal agenesis is incompatible with life because it is associated with pulmonary hypoplasia and Potter facies due to oligohydramnios. Then multicystic dysplastic kidney, MCDK. Okay, this results from congenital severe renal dysplasia in which the kidney composed of a mass of various sizes in a loose stroma. If bilateral, it is incompatible with survival of the fetus. It is mostly diagnosed on the prenatal ultrasound scan and is apparent as a palpable mass in a newborn. So most common cause of a palpable mass in a newborn is multicystic dysplastic. Previously surgically excised, but now it is treated conservatively. One second. Hello. Sorry. Okay. Multidystic dysplastic kidney. Then coming to ectopic kidney or transit renal ectopia. The fetal kidney arises in the pelvis and ascends to attain its normal position. So remember, the testis developed in the abdomen will be descended to scrotum, whereas kidney arises in the pelvis and it ascends up into the retroperitoneum. If this process fails to any degree, the kidney ends up in being lower than normal position. During their ascent, the renal pelvis also rotates from facing anterior to facing more medially. That is rotation of the kidney along with the ascent. The most common anomalies of renal pelvis to face anteriorly and more ectopic the kidney, the more severe is the rotational anomaly. See, this you need to know. This is the kidney, this is the ectopic kidney. So this ectopic kidney and this normal kidney gets fused. This is called as crossed renal ectopia. See, in majority of cases, the crossed renal, in case of renal ectopia, the both kidneys are fused. In crossed renal ectopia, both kidneys are fused on one side, and the one of the ureter usually therefore crosses the midline to enter the bladder on the correct side of the trigon. See, this is of opposite side kidney. This has come to this side. This is the same side ipsilateral kidney. How you will be knowing it? Because of the ipsilateral ureter entering into the ipsilateral side of the bladder. Whereas the opposite ectopic kidney comes and fuses to the ipsilateral kidney. So this ureter will join normal into the same, it's a regular and anatomical bladder, into the anatomical bladder. So this ureter will cross to the opposite side. This is called as crossed renal ectopia. This is very important short notes for you. Very important among whole urology part, which is very important question is horseshoe kidney. Why? Because it is called as horseshoe kidney. It is because of the fusion of the lower poles of both kidneys. Like I will be showing you a diagram. Yeah, this is the horseshoe kidney. See, remember I will be explaining from here. This is the opposite. This is one kidney. This is one kidney. There will be fusion of both lower poles of both kidneys, forming a horseshoe kidney. See, looks, it's like a horseshoe. This part is called as isthmus. It is formed because of arrest of ascent of kidney by inferior mesenteric artery. Note, these ureters are coming over the isthmus, not posteriorly. It is coming anteriorly to the isthmus. This isthmus is usually located at the level of L4. See, this I will be explaining here in theory. It is a developmental anomaly where there is a failure of complete ascent of kidney with the fusion of lower or upper poles, usually lower poles. Fusion of lower poles is more common, rarely upper poles. The further ascent of fused kidneys is prevented by the IMA, inferior mesenteric artery. This condition is most common in males. The most common site is located at the level of L4 vertebrae. I told you, right? The part in front of vertebrae is called as isthmus. Isthmus is located at the level of L4 vertebrae. Clinical features: it presents as a fixed, non-mobile, firm mass in the midline at the level of L4 vertebrae, which is resonant on percussion. Horseshoe kidneys are more prone to reflux, obstruction, and store formation because of this position. See, normal kidneys will come like this, whereas the horseshoe kidney, see, it is coming like this. So, chance of compression by the isthmus is very high. So, the chance of reflux, obstruction, and store formation is very high in patients with horseshoe kidney. Very important characteristic appearance of horseshoe kidney on intravenous ureterography is flower vase appearance. And other investigations are ultrasound abdomen, urine analysis, blood urea, serum creatinine are supportive investigations. Then you can also perform CT abdomen and CT angio. Treatment: whatever the complication occurs in horseshoe kidney, it is usually treated according to the complications. Per se, separation of isthmus is not indicated unless to approach of aorta for aortic diseases. For kidney per se, it is no need to divide the isthmus. Then duplex renal pelvis and ureter. Duplication of ureter and renal pelvis is a common anomaly with an incidence of approximately 1 in 150 births. Unilateral duplication is 6 times more common than bilateral, and left side is more commonly involved. The condition is most common in girls. Ureter duplication occurs when there are two separate ureteric buds, one in normal position and another in lower position. This duplex system. So these two combines and forms normal experiment. This is the normal upper one. This is opening lower. See, this is called as Weget-Mayer law. This I will be explaining you in the diagram. See, remember this Weget-Mayer law. This is the kidney. This is bladder. Remember, see, this is the upper ureter, right? This is lower ureter. Two ureters are there because it is duplicated ureter. This upper ureter, follow this. This upper ureter is opening lower, whereas this is the lower ureter. This lower ureter is opening upper. So remember, that is Weget-Mayer rule. According to Weget-Mayer rule, the upper ureters are located and opened more lower position, whereas the upper ureters are located located in the more upper position. It is called as Weigert-Mayer rule. These are more prone for reflex, obstruction, and stone formation. The normal bud ends in the correct side in the trigon of bladder and it's non-reflexing. The lower pole ureter is often associated with vesico-ureteric reflex. In adults, the condition is usually asymptomatic, but children, the duplex ureters usually have associated vesico-ureteric reflex. These things, vesico-ureteric reflex, everything will be covered again in later part by professor. So just remember the congenital anomalies because these are very important for short notes, like 4 marks or 2 marks. The spontaneous resolution of VUR is less common in patients with duplex ureter compared with patients with single ureters. Investigations. IV use the diagnostic investigation. Ultrasound to look for the complications. On cystoscopy, you will see a double ureteric orifices on same side, and DTPA scan is also used to perform to see the function. See, this is the duplex system. This is the normal system. These are the calyx opening into the ureter. See here. Here there are one calyces and this is one ureter. This is another ureter. This is called as, see, urogram on left side showing double pelvis. You can see two ureteric orifices. This is one ureteric orifice. This is one ureteric orifice. Treatment. Ureteric meatotomy is done if there is narrowing of the orifice. The coexisting complications are treated. Often heminephrectomy includes removal of corresponding ureter may be essential as a treatment because there will be constant vesico-ureteric reflex. That is the reflex of urine from the bladder and ureter into the kidney. Constant reflex, it will leads to damage of kidney, leading to babies with renal failure. So in females with complete duplication, lower ureteric orifice is ectopic, causing urinary incontinence, which needs partial nephrectomy or ureteric reimplantation. Coming to ureterocele, it is nothing but a cystic enlargement of intramural portion of ureter due to congenital atresia of ureteric orifice. Its wall contain mucous membrane only. Usually, there is a concept called of ureterocele because of not rupturing Schwelli's membrane. Because of unrupture of Schwelli's membrane, that patient will develop ureterocele. Complications of stone, recurrent infection, and hydronephrosis. Treatment of ureterocele is transverse incision. Yeah, this is characteristic cobra head appearance on IVU. On cystoscopy, you will be seeing a translucent cyst which is thin walled surrounding the ureteric orifice. Then treatment is cystoscopic ureteric meatotomy that you have to give transverse incision. So this is the ureterocele. See, because of there is an opening here. There will not be any opening here because it is occurring because of failure of rupture of Schwelli's membrane. It will form ureterocele. This is cystic dilatation of lower intramural part of lower ureter. It is called as ureterocele. See, typical cobra head appearance. See here, typical cobra head appearance on IV. Retrocaval ureter. Retrocaval ureter is because of persistent posterior cardinal veins. Very important thing. Retrocaval ureter occurs because of persistence of posterior cardinal veins. It is due to development defect of IVC, as a result of which right ureter passes behind the IVC, causing right-sided hydronephrosis with upper third hydroureter. The IV shows hydronephrosis with reverse J-cell. Treatment is Anderson-Heinz operation. Anderson-Heinz operation is nothing but pyelopyeloplasty. This you will be seeing in further classes. Then cystic disease of kidney. I think these things will be covered in the next class by Bhaskar sir, new professor of surgery. This is the nothing but anatomy and congenital anomalies of the kidney. Any people have any doubts, just ask me, I'll try to explain. This is the anatomy, blood supply, nerve supply, lymphatics, ureter anatomy. These are the congenital anomalies. In these things, very important is horseshoe kidney. If you see this diagram, you must be able to write the whole 4 marks answers.
Sir, what is the origin of suprarenal glands? Suprarenal glands.
Suprarenal gland is again from the mesoderm.
Intermediate mesoderm.
Hello?
Sir, intermediate mesoderm only, sir.
No, not intermediate mesoderm. See, the concept of adrenals and kidney is very, very different. There is no diagram, sorry, but if possible, I'll explain you in the next class. Kidney, see, remember the concept of kidney, remember pronephros, mesonephros, and metanephros. That is nephros. Pronephros, mesonephros, and metanephros. This pronephros, these three things are usually located in everybody. This pronephros will be regressive spontaneously. This mesonephros will form mesonephric duct, from which this ureter, this vas deferens, everything will form. Whereas this metanephros is there, right? From this metanephros, there will be metanephric blastemia, and from metanephric blastemia, it will form kidney. So kidney is formed from intermediate mesoderm, whereas adrenal is not at all related in embryologically related with kidney. That is why in patients with unilateral renal agenesis, adrenals will form normally. Adrenals will be located in normal position, but the shape of the adrenals will alter. That's it. This is the very important concept you need to know. If you think that both adrenals and kidneys are arising from the same intermediate mesoderm, in case of unilateral renal agenesis, there will be also absence of ipsilateral adrenal gland. But in any cases, till now, no cases have been reported that unilateral renal agenesis is associated with adrenal agenesis, because adrenal will be located in normal position, position only, but shape will be altered. Did you understand?
Yes, sir.
Yeah. Further doubts? Any doubts?
No,
This is
sir.
very important law. We get Mayer law. This everything is from Bailey only. You can go and read it again. Most of the initial chapters have been covered by me today. Rest will be covered by Bhaskar Rao sir from next Wednesday. Okay, thank you.